Hello and welcome to an IAPMD patient webinar for World Bipolar Day on PMDD versus bipolar.
My name is Professor Arianna Di Florio. I'm a clinical psychiatrist and professor of psychiatry at Cardiff University. I'm really curious to know how the closed caption will work with my English. I hope this will be clear. So I have nothing to disclose financially. In this session, we will talk about bipolar disorder and premenstrual disorders, in particular premenstrual dysphoric disorder. And we will try to answer three questions. The first questions around bipolar disorder, what it is and how is it managed. Then we will talk about the differences between bipolar disorder and premenstrual dysphoric disorder that from now on I will call PMDD, and what is similar but also what is different, and the tricky differential between the two and how we can tell them apart. And we will conclude this webinar addressing the question whether you can have both PMDD and bipolar disorder. This is a question for the general audience. You don't need to have any background. However, the slides that I have prepared for you are based on the scientific literature, although there is not much there in terms of research studies. However, there are old-fashioned books that always work for general information, and also I'll base my talk a bit on my personal, clinical experience, being the director of the reproductive mental health clinic, and about my clinical experience with my patients. Again, this is for a generalist audience, but the slides are quite rich. There will be a lot of references to the literature, and the way it works, you'll see sometimes a PMDD number on the slides, and this refers to the PubMed reference to the papers that support the claims I'm making. So what you can do if you're interested about this, if you're a bit geeky like me, you can just Google the PMDD and the number, and usually the reference, the paper comes up and you can read it. And this is an example on how you can do. This is how it looks in the slide, and this is what you find in using Google. It's important to understand what is this differential diagnosis thing, what does it mean, what is this all about? And I think it's important to understand that here we're using words to communicate, and what is a diagnosis and what is a psychiatric disorder. So the way it is, if you go to the doctor and you think you have a psychiatric disorder, and the way that the diagnosis is made is using usually a manual, and it's either the International Statistical Classification of Diseases, which is the manual edited by the World Health Organization, or the Statistical and Diagnostic and Statistical Manual of Mental Disorders, which is edited by the American Psychiatric Associations. And these manuals provide basically definitions of the various disorders you can have. And there are several advantages and disadvantages in this approach. One of the advantages is that if you are told that you have, for example, bipolar disorder in the United Kingdom, and you move to, I don't know, South America, to Brazil, for example, the disorder will always be the same. It's always, like we mean the same thing with our words. And so that allows us to know the burden of diseases around the world. So how many people suffer from diseases. It allows us to run studies about treatments. So, you can treat the disorder in the same way, like worldwide and so on. So there are advantages to this approach. The disadvantages are that these manuals are, of course, quite black and white, which is what we call categorical. You either have a disorder or you don't have the disorder. They don't do gray, they don't do middle grounds. They either have something or not. So it's a very yes or no type of situation in psychiatry that might not mirror actually the distress that the person has. People are really complex, and probably black and white situations don't work very well for brains, for minds, and for people, for life. Really, it's not black and white, but this is the way we do that. That's probably the best way available at the moment. And the other issue is that they are symptom-based. So today we will talk about list of symptoms in psychiatry to have any diagnosis. And this is something that is rooted in the European psychiatric traditions. You know, like we have been now for centuries describing disorders based on symptoms. So we don't have blood tests. We don't have any test, actually. The, biological test, lab tests more generally. And we use lab tests, though, to make sure that the symptoms we see are not caused by, for example, brain tumor or thyroid problem and so on. But, you know, like the diagnosis are based on the observation of how a person behaves, how a person feels, and what a person thinks. So this applied to bipolar disorder, for example, looks like this. So what is bipolar disorder? On the left here, I provided you with a description that famous person with lived experience, Kay Jamison. She's a psychologist with lived experience with bipolar disorder, and she has authored this beautiful book about her own experience with bipolar disorder. And you can see how she describes it. She describes the highs of bipolar disorder as wild, impulsive, chaotic, energetic, and crazy moment of her life. And the lows are a moment in which she is shy, withdrawn, desperate, suicidal, doomed, and tired. And you can see really the personal account. I find this description really touching. And, you know, like all the issues associated with bipolar disorder, credit cards revoked, bounce checks to cover, explanations due at work, apologies to make. And this is a really live description of the consequences of bipolar disorder for a person that suffers from it. And on the right here, there is a bit more, the colder, if you want, the more academic description given by DSM in this case, which is for bipolar 1 disorder, which is the most severe form of bipolar disorder, which is what Kay Jamison describes. And it says it is necessary to meet the following criteria for a manic episode. So we have criteria and a list of criteria, and these manic episodes, which are the core aspect of a diagnosis of bipolar disorder, might be preceded or followed by either hypomanic, so many episodes of less severe forms of mania, or episodes of major depression. So the core of bipolar disorder is mania, or in its less severe form, hypomania. And mania, again, according to DSM, is a distinct period of abnormally and persistently elevated, expansive, or irritable mood and goal-directed behavior or energy. What does this mean? It means that, first of all, there are distinct periods, so you can recognize that there is something wrong going on. It's not just a subtle feeling, it's something quite, like marked. It's really different from what a person normally feels or the way normally a person behaves. And the mood is really, really high, and it can be not only joyful, but also irritable. And this is not enough to have a diagnosis of mania according to DSM. You also need to have a lot of energy and what they call goal-directed behavior. So, for example, you might notice that you start having, like a lot of energy and cleaning the house at 3 a.m. So that is what we mean for a lot of energy and goal-directed behavior. There are some additional criteria. So the core of mania is really the mood that can be irritable or expansive, and the energy, but there are also other symptoms that need to be present, such at least 3 or 4 of these, including grandiosity, decreased need for sleep, being more talkative than usual, having this experience that your thoughts are racing, that you have a lot of thoughts all at the same time. You're very easy to be distracted, and there is usually excessive involvement in activities that can be painful, or harmful. And Kay Jamison, remember, talk about her credit cards being revoked and so on. So it might be sexual, like buying sprees or sexual discretion and so on. So I think it's something that, again, a description is quite flat. I find descriptions really flat. I've put here 3 links, if you wish, on educational videos of mania with actors portraying, like a manic episode, in case you want to see how that looks. Bipolar disorder then is characterized by these core manic symptoms, but then there are 2 subtypes mainly. Bipolar 1 disorder, which the key feature is mania, again, which is the severe form of high mood. And then there are people, however, that never reach that level of severity, but they still suffer from less severe episodes of mania that we call hypomania, and episodes of depression. And usually this is called bipolar 2 disorder. And this is this picture comes from a very nice lovely graphic novel about, again, bipolar disorder from person with lived experience perspective, Marbles, which I also recommend. The longitudinal, so these are discrete episodes, we said, of mania, but the reality, and this is a plot of the mood by asking, this is a study we have run, and on the longitudinal course of bipolar disorder. So we are asking every week people with bipolar disorder to rate their main manic symptoms and the depressive symptoms. And as you can see, there is a lot going on. There is a lot, this is way more complex than those discrete episodes that manuals, describe. There is way more complexity. And also, as you can notice here, despite mania being the core feature of bipolar disorder here in red, it's depression actually what bothers people. You see here that the depressing scores are quite high, and that is what really bothers people. So how do we manage bipolar disorder? This is a very busy slide. And again, I put this slide for people that have a more specialist or professional interest in this. This comes from the international guidelines from the International Society of Bipolar Disorder and the Canadian Network for Mood and Anxiety Treatments, which is called CANMAT. And it's a pretty solid reference. And what I like about this table is that not only tells you the treatments and how much they work and for what they work, but also tells you about safety concerns and tolerability concerns, because like the treatment for bipolar disorder usually is lifetime, or at least for a few years, depending. Like it's a recurring condition, so it requires treatment for long periods of time. And for manic episodes, so for the highs, the first line treatments are usually what we call mood stabilizers. The most famous probably one and the most widely used is lithium, which is a metal, and it's quite cheap but extremely effective. It requires blood monitoring. Long term, it can get issues because it requires long-term blood monitoring. Another quite common treatment is an anti-epileptic, which is called valproate. Here is the Valprex, it's got different names. And then there are other mood stabilizers that actually come from more the world of antipsychotics. So there are new drugs that are still called second generation antipsychotics. Usually these are medical terms like quetiapine, aripiprazole, risperidone. These are usually the most effective evidence-based treatment for mania. And then for the bipolar depression, and I think this is where I want really this is what I want to highlight to you, because in general, if you think about depression, in the general population of depression that you go to the GP for, or something that, like about 10 to 20% of people actually experience in their lifetime, usually what you are prescribed is an antidepressant. They are called usually SSRI, fluoxetine, sertraline, these type of drugs. However, this is different from the depression in bipolar disorder. Bipolar depression is another thing. It requires a different type of treatment, different considerations. And again, as you can see, the first-line treatments for bipolar 1 depression are mostly, again, mood stabilizer, lithium, lamotrigine, quetiapine. So we see, again, these drugs. And the SSRIs, which are type of antidepressant, usually don't work. You know, there is not much evidence for their benefits and effectiveness in bipolar depression. And even if you give them without a mood stabilizer, they can actually trigger manic episodes. So the take-home message of this slide is that antidepressants that might be given, for example, for PMDD as well, do not work in bipolar disorder. So this will be a recurrent message of this talk. I'm going to repeat again and again and again because it's really important. Diagnosis is really important because it matters for treatment. Treating bipolar depression as if it is PMDD or as if it is a unipolar depression or something else does not work. The treatment is different. And as you can see, the first-line treatments for bipolar depression do have some, as many drugs, they do have actually side effects. So you want to make sure that they might have side effects. It's not that they always have side effects. They might have side effects, so you want to make sure that they are prescribed only when it's needed and there is a real diagnosis of bipolar disorder. So if you have PMDD, you don't want to be treated like you had bipolar disorder. So to recap, what is bipolar disorder? It's a mood disorder characterized by episodes of high mood. It's often cyclical or recurrent. Irritability and depression can be present. Depression is actually one of the main concerns for people with the disorder. The first-line treatments are mood stabilizers, okay? Not antidepressants, but mood stabilizers. And antidepressants can actually have a negative impact on the illness. So how is bipolar disorder different or similar from PMDD, and how can we tell them apart? So again, a recap of what how DSM defines premenstrual dysphoric disorder. The main criteria, of course, is that it's as the word premenstrual suggests, it's a disorder that is present in the final week before the onset of menses and starts to improve within a few days after the onset of the menses and become minimal or absent the week post-menses. So this is key. It's related to the menstrual cycle and is usually in the second part of the menstrual cycle. The symptoms, as you can see, there are overlaps with bipolar disorder because we're talking again about mood symptoms like mood swings, definitely sad, tearful, irritability, again, key symptoms of bipolar disorder, again, depression, anxiety. So these are all very core mood symptoms in PMDD as much as in bipolar disorder. For completeness, we want these symptoms to be severe enough. And I think this is key because many people suffer from premenstrual symptoms. They are very common, but PMDD is something different because PMDD is associated with a clinical significant distress or interference with work, school, or social activities or relationships. So if you suffer with PMDD, you might not be able to go to work when you have the symptoms, like it's extremely distressing disorder. And it's not an exacerbation of other disorder, and it needs to be confirmed longitudinally. So you need to keep a diary for at least 2 menstrual cycles to confirm the diagnosis. So what are the possible overlaps? In bipolar disorder, we talk about irritable mood. In PMDD, we talk about irritability. It's a bit the same. Then we have mood instability, mood swings, depressed mood, and anxiety. And I'm going to tease them apart one by one. So starting with irritability, irritability is difficult to define, and I think it's important for us to have a good, good knowledge of what emotions and feelings are. Irritability is a heightened sensitivity to stimuli. Okay, it's different from anger or aggression, but it might lead to anger and aggression. So you just been oversensitive to events, to any sorts of trigger and stimuli. it's a common feature of many disorders, including, as we said, bipolar disorder and PMDD, and it seems to be more common in females. And I want to pause on this idea and try to contextualize this information for you, and invite you really to reflect on this, because so far we've really adopted here a medical paradigm in which we're talking about disease, really biological stuff. But people develop disorders, like not in a lab, but in the real world. And the real world is sometimes really, really difficult for women. And here I pause a moment because I'm going to mention suicidality, suicide and abuse. So if these ideas are upsetting for you, please step away or mute for 2 minutes, like if you feel this is too triggering for you. So these are statistics from the United Nations. You can find these on the website. And if we talk globally, 30% of women have been subject to physical or sexual violence at least once in their life. And the majority of cases is by their partner, actually. And it's not better for young girls, really, which almost a quarter of them have experienced physical or sexual violence from a partner. I find these statistics absolutely horrific, and I would have never, if I was not doing this work, I would have never imagined this is so bad. Like times are changing, and now we're talking also about cyber harassment, for example, which is spread worldwide, way more, again, than what I had imagined. In the European Union, about 1 in 10 women report having experienced cyber harassment since the age of 15. Pakistan, 40% of women had faced various form of harassment on the internet. And in the US, 1 in 5 young women have been sexually harassed on the internet. 1 in 2 says they have sent unwanted explicit images. And this doesn't get, although we know that especially physical violence and sexual violence are associated with socioeconomic factors, even women in politics, and I find this even more, it makes me really, I get irritable reading these numbers for you. And across 5 regions in the world, 82% of women working in politics, parliamentarians, have reported experiencing some form of psychological violence while serving in terms. And the UK, where I'm based, we know that actually young women are a high-risk group for self-harm, with about 1 in 4 of them having self-harmed, and very high levels of post-traumatic stress disorder. And we know that in terms of time trends, the gap between young women and young men is increasing. The UK Office of National Statistics highlights that suicide rates are increasing in young women, and between 2015 and 2021, young women, together with women between the age of 25 and 44, have had a statistically significant increase of complete suicides. This is really, again, horrific numbers, in my opinion. And I think they tell us about the general conditions of women, and irritability, I think, really sometimes, not always, is really a healthy response to this. Definitely an understandable one. Another factor that contributes to irritability that is not much spoken about, or if it's spoken always in a judgmental way, which is absolutely not my intention today. It's just to inform you about factors that might trigger irritability without thinking about bipolar disorder or PMDD. But even in women with an AFAB with PMDD and bipolar disorder, this is a modifiable factor that can improve things, which is or make things worse, which is alcohol. And we have observed in the during the pandemic an increase in the number of alcohol-specific death, of a quarter. And although men consume more alcohol than women, there's still an increase in women as well. if you want to know a little bit more about alcohol, we know that we should it's recommended to keep it low, usually lower than about 14 units. But actually, recent studies have shown that any amount of alcohol is not great for well-being. And I'm always surprised, like if, when you think that a can of lager can have 2 to 4 units of alcohol, and you have an allowance, let's call it allowance of 12, 14 like units a week. You have 3 cans of lagers in a week, and you're done with your allowance. So I think there is way more alcohol around than what you think. Definitely about way more than what I used to think. So the other thing that bipolar disorder, characteristic symptom that mood disorder, bipolar disorder and PMDD share is mood instability. Again, this is a slide for geeks like myself. What you need to know here is that mood instability has got several names because it's difficult to define things. As this slide says, there are 24 different ways of measure and mood instability. There are a number of definitions. You can call it dysregulation, emotional variability, mood swings, emotional impulsiveness. And I think it's important for the general public to know this, because sometimes you think 2 different terms are used and you think are 2 different things and you get confused, but actually it's a little bit more the same thing. And it means that you have these very rapid and intense oscillations in your mood that becomes really difficult to regulate. You're not really much in control of it. And this is actually quite common. Again, this is a previous survey, 2007, that it was over 10% of the population has reports mood instability. Is particularly common in women, and again, in young women especially. And it's a feature of several disorders, and it really affects the outcomes of the disorders. And I think this is a good point, again, to stop and have extra reflection on what is called borderline personality disorder or emotional unstable personality disorder. And I'm really passionate about this because I think it's a disorder that is stigmatized as, in my experience, no other. I really don't understand why it's so rejected. There is a rejection towards this diagnosis, both by healthcare professionals and people with lived experience. And it's a differential diagnosis of both PMDD and bipolar disorder. So this is why I'm talking to you about this today. And again, we have mood swing, mood instability, irritability to the point of anger, self-harm, which unfortunately is common, and suicidality, which unfortunately are both common and different forms and extents in both bipolar disorder and PMDD. There might be even psychotic breaks at certain points, and there is an interpersonal instability as well. I've put below here this figure comes from review by Gunderson and colleagues. It's a very, I think, instructive review on borderline personality disorder, and you can see in the history of this disorder that that this is really a history, is a very, very tormented, I would say, story, and with a lot of changes. And I think this really reflects the stigma, and again, it's a disorder that affects predominantly women, so I think that is also not helping. However, again, very important to recognize if it's bipolar disorder, borderline personality disorder, and not PMDD and not bipolar disorder, because medications actually should not be used to treat borderline personality disorder. And however, for some reason, and I think again, because it's a stigmatized diagnosis that the body for some reason wants to have or wants to give, about 40% of people with borderline disorder are on 3 or more psychotropic medications. And bear in mind, I've just told you that probably these drugs actually don't work. And so what does work for borderline personality disorder? Well, the evidence, again, from the Gunderson review here is summarized in the table on the left, is really psychotherapy. There are several types of psychotherapy, and psychotherapy probably is more hard work than like taking a pill, but it actually works really, really well. And this on the right is a graph. It's from an old, relatively old paper, 2006, and it shows here the top line. It shows you the difference between the top line, which is psychotherapy to address the borderline personality disorder, versus this other line, the low line here going down, is the line for no treatment as usual. And you can see this shows you how many people remain well, basically, not attempting suicide in 2 years after having dialectical behavioral therapy, which is a type of psychotherapy, versus normal treatment. And you can see the difference. And actually 80% of people with this disorder, which is usually considered very severe and almost hopeless, actually respond to the treatment, and they are well after 2 years. So I think, again, diagnosis is important. There is hope, and I really, really don't see why we should not address this disorder correctly. Again, borderline, I mentioned this here also because people with borderline personality disorder tend to really feel the effects of hormonal fluctuations. So their disorder can be exacerbated by the menstrual cycle and complicating the picture further. So this is another characteristic that links menstrual disorders with mood disorders and borderline personality disorder. So how is bipolar disorder similar, different from PMDD, and how can we tell them apart? Timing here is key. Timing. So mania requires distinct periods of high mood, and they don't follow the menstrual cycle. They happens not necessarily in relation to menstrual cycle, and they don't happen every month. It's not that you have a manic episode in the luteal phase of every month. PMDD, on the contrary, has got this link with the menstrual cycle, and usually it's what we call the luteal phase. So the last, according to DSM, is the final week before the onset of the menses, and you should be fine, absolutely fine, after your period. Borderline, on the contrary, is a quite disorder that is quite chronic. It's quite always with you if you don't treat it, and it begins in early adulthood and is present in a variability of context. So really, if you want to distinguish these three disorders, you need to monitor your symptoms every day for a couple of menstrual cycles every day to see where your symptoms are and where your periods happen, and see how that looks. For bipolar disorder, we talk about mood monitoring, for life charting. For PMDD, we talk about menstrual diary, but the concept is really to record your symptoms, whatever they are. It doesn't need to fit DSM definitions. I think I'm absolutely against the fact that a person needs to fit a manual. I think manuals should benefit people. So it needs to be personalized according to your needs. Can be pen and paper. Now there are a lot of electronic, apps and stuff that do that. And really, if you see that, you can learn a bit about yourself and can actually provide reassurance and immediate feedback. So can you have both PMDD and bipolar disorder? If we go back to DSM, the book, the answer is clearly no, because it says clearly as a criterion E that the disturbance is not merely an exacerbation of symptoms of another disorder, such as major depressive disorder, panic, and of course, personality disorders, so borderline, but also bipolar disorder. So no, it's a distinct thing. You can have a history of another disorder. So for example, people with history of major depressive disorder can then separately develop premenstrual dysphoric disorder, but they cannot co-occur. So there are two tricky situations here. PMDD in people with history of bipolar disorder, but also the exacerbation of bipolar disorder, like circummenstrual, but especially the week before your period. There is no much research on this, no much information, and Wonderful Claire Dolman with Bipolar UK has a series of webinars if you're interested in this and other what I call women's issues and bipolar disorder. There is a series of webinars organized by Bipolar UK and really hosted by Claire that I highly recommend. And Claire and for Bipolar UK has run a survey on people with bipolar disorder called the Women in Bipolar Disorder Survey. And because there is not much literature on this, and Claire has asked whether the menstrual cycle has ever affected the bipolar symptom in people with bipolar disorder. And as you can say, quite a significant majority of people are impacted by the menstrual cycle in their bipolar disorder. Most of them is slightly or a bit, but again, a significant number says quite significantly. So there is something that is not captured by the current medical system. And to prove what I say about the healthcare professionals not knowing much about these issues, when Claire asked whether the healthcare professional, have ever spoken with people with women with bipolar disorder about this, the answer has been no. And women think really that healthcare professionals should learn more about menopause, but also about menstruation in general by women's health in relation to bipolar disorder. Bipolar UK has got also a statement out at the moment that you can read on women's health. Really, I strongly recommend that website for more resources on this. And to mirror what Claire has found in her work, here, if you just go again to PubMed, which is what usually doctors do, and you look for menstrual and bipolar disorder, you don't really get much entries. You get only 164 entries, mostly reviews, case report, or really, like studies with more small desires, more sample size, talking about symptoms rather than disorder, with a lot of bias in sample selection, lack of replications, really studies we cannot rely on to inform our clinical practice. What we know, though, is that lithium and valproate, which are the main mood stabilizers used in bipolar disorder, are associated with menstrual abnormalities. And here I wish to remind you that valproate should not be prescribed in women that can get pregnant, okay, because it can cause issues with the fetus and with the baby, so they should not be prescribed. However, if it's prescribed, it's associated with menstrual abnormalities. Lithium concentration might vary across the menstrual cycle, so you might have too much or too little lithium, like that is also something that's not studied very much, if not at all, but that is also another issue for women with bipolar disorder, and there are possible associations between bipolar disorder and menstrual dysfunctions, or here these complicated names basically mean what is usually known as polycystic ovaric syndrome mostly. And as you can see, there are several references here. So what can be done? I think, again, I can't stress this enough, it's important to get the right diagnosis to get the right treatment. In fact, if you get the wrong treatment, again, antidepressants can trigger mania. Pharmacological treatment is not recommended for borderline personality per se. And when I say pharmacological treatment, I mean, anything here that we're discussing. Also, the evidence for the effectiveness of hormonal treatment for premenstrual exacerbation of borderline personality disorder, in my opinion, is not there. So, there are very complex treatment considerations in bipolar disorder and borderline personality disorder that need to be made. Antipsychotics and mood stabilizer are not currently indicated for PMDD, and they can come with significant side effects. So if you don't need them, or you should not have them. And case reports of hormone-based treatments show that they might or might not, it's not clear, but they might cause bipolar disorder. And in any case, hormone-based treatments don't treat bipolar disorder. And finally, like mania and affective psychosis or psychiatric emergency, a person that's having a manic episodes need urgent medical assessment, and very often, like robust treatment, crisis treatment. So we can't confuse diagnosis here. So how do we make this diagnosis? First of all, as I said, we need to exclude other medical conditions, thyroid problems, but also, coffee, alcohol, cannabis, and painkillers don't help the mood. So that is also something that needs to be considered, especially if they are taken in excess. Then we need this mood monitoring that it's frustrating, but it needs at least for 2 months to be daily. And any symptoms you have, it doesn't need to be something that, again, is codified it's your story, it's your life, so the symptoms you feel, and that it helps to link them to the menstruation. And the terminology, medical terminology, we've seen just for mood swings, mood instability, the terminology is really complicated. Just use the terms that work for you. That is my advice. And then the doctors will figure it out with you. And it's important always to remember that premenstrual symptoms are really common, and they are absolutely fine. They're normal. They are perhaps not pleasant. They are not the best, but this is not PMDD. PMDD, the severity is on another scale, really, because this, this is a disabling condition. So, that severity criterion is really, really important. And for this, again, mood diary, mood monitoring, call it as you want. Live charting, menstrual diary needs to be personalized, as I said. Pen and paper, you can build your own. You can download. PMD has got one for PMDD on the website. Build your own if the symptoms don't correspond to your experience, but just do that for 2 months. I know it can be frustrating, but that is really, really key. Otherwise, you end up with a treatment that perhaps you don't need, or actually can make you feel worse. And finally, and I think this is, again, something I find really important, but it's not usually considered, because usually you go for a doctor appointment, the doctor doesn't have much time, but I think an in-depth personality assessment is absolutely key, because the way we think, we feel, and we behave, it's different in all of us. We're all different. Standardization helps, keeps the standard a bit high. If it helps training people, it helps communicating people, but actually you are you. And I think the personalized assessment, considering personality and, things that might not be visible to you immediately, and that doctors might over time recognize, with time, with getting to know you, are really important. And I think really sometimes what matters is not visible, as the Little Prince says. So there are a lot of unknown, as I said. We don't know very well. There is not much literature. So what we're doing now in Cardiff is we're running a very big study. We hope to recruit 1,000 women with premenstrual dysphoric disorder to understand, the causes of it, both in biological terms and environmental terms, and the, where PMDD sits in the diagnostic classification, what it shares with other disorders in terms of biology, like bipolar disorder, like borderline personality disorder. So we really want to learn a little bit more about premenstrual dysphoric disorder. So if you're interested in taking part, this is a QR code. Apparently, if you take a photo of it, it should take you to the page of the study. So if you want to learn more and take part, that would be fantastic. I want to conclude by thanking the team. I've got many people to conclude, to thank, of course, Laura and all the team at IAPMD, my colleagues at the NCMH in Cardiff and BDRN, the Bipolar Disorder Research Network, Claire, my colleague in North Carolina, David Rubin and Samantha Malzer-Brody, and the wonderful Predict team, the wonderful team that is conducting the study on premenstrual dysphoric disorder, including Chloe Apsey. So thank you very much. This is my email if you want to email me with any questions after this. Thank you.
That was amazing. I learned so much. Thank you so much. I really, really appreciate that. Just quickly, for anyone wanting to learn more about the Predict project, I've just popped a link in the chat. We will also be doing a Facebook Live and an Instagram Live next week, and the week after, with Chloe, who is Dr. Di Florio's one of her research assistants. Oh, thank you. And for anyone who has found this webinar beneficial, please do make a donation. I know you pay to be here, but please continue to donate. It's what keeps us going, and it means that we can do more to help more people. So if you are able to, please do make a donation. So we will be doing some lives with Chloe from Dr. Di Florio's team. And we also will be in Cardiff. For those who are in Cardiff, let me just share a link, or if you're nearby. We will be there on the 26th of April as part of PMD Awareness Month. We will be at the Pierhead in Cardiff. I'm just getting the link up now. Apologies. Should have had that one ready. So many links. So little time. There we go. So if you wanted to come and meet Professor Di Florio, then please do pop along there. It's a drop-in event and all the details are there. Right, so we're just going to work through a few questions, if that's okay. Let's have a look. So I'm going to kind of start at the top. And I don't know if there's an actual, we know this, is there a difference in rates of PMD diagnosis in Europe versus the US? I'm in the US and diagnosis seems uncommon here.
I think one thing is how many people suffer from the disorder, and the other thing is how many doctors find out the disorder. And I think that is a big difference, and I think it really depends on the area, because even within a country, if there is a doctor in the area that is quite knowledgeable about this, you can have a rate of disorder. And there are also other contexts where the disorders might be misdiagnosed. I mean, although it's very difficult, but it might be that it's overdiagnosed in certain contexts, or there is confusion between premenstrual exacerbation and PMDD. So I think putting a number, it's difficult because it depends what you mean with that. That would be my answer. Laura, what would you say?
I would agree with you, and I think it's really, really difficult to know at the moment, just because the lack of education in providers. One, you know, numbers we do have don't account for misdiagnosis and overdiagnosis. And also, so in the US they have the DSM-5 looking, so there's and the ICD-11 code only kicked in, so making PMDD, I should say, was added to the ICD-11 in 2019, which makes it an international official diagnosis, which is amazing. But the code for that only kicked in I think beginning of 2022 or 2021, I can't remember. So the tracking has only really just started, so it's really, really difficult to get that data. I think we don't know yet, but hopefully, you know, in a couple of years we'll actually sort of be able to start building up a better picture of that. Okay, another question from Larissa. So if hypomania only occurs at or around ovulation for 2 to 3 days and at no other time, would that indicate bipolar disorder?
So for hypomania, alone, without a history of depressive episodes, usually it's not considered a bipolar disorder. Also, the recall of hypomania usually in people is relatively difficult because it's actually it can be a pleasant state, and the issue is more the subsequent depressive episodes of the consequences of hypomania. It's interesting, this link with ovulation, because again, and this is why we're running these studies, because these phenomena are not captured by DSM. So if you have only ovulation, issues, hypomania around ovulation, that is not bipolar disorder, because that doesn't fit the description of DSM. However, this is something that actually happens to people, and we will need to address this to know what to do. What do these people do? So this is not, if we want to be rigid with the criteria, this is not But I think in general, hypomania, it's important when it's accompanied, because of the depressive side of the coin, because usually hypomania is pleasant, depression not very difficult to treat, and that is then why differential diagnosis become key, because bipolar depression is different from unipolar one. I hope that answers the question.
That was, yeah, really interesting. Thank you. Alison has asked, is it possible to have a mixed episode for that last 12 months?
We know that women, female tends to suffer more from mixed episode than men, and again, that is unfortunately possible, especially if it's not treated, or is usually we see that if a depressive episode is treated only with antidepressants in a person with a bipolar, underlying condition that's not being recognized, that can happen. Usually, these mixed episodes are not extra severe, because usually if something is extra severe, you are admitted to hospital, diagnosed and treated. But actually there is this insidious type of mood instability that, requires a lot of knowledge, because a mixed episode can be mood instability, what's the difference, what is the underlying cause. So it's possible, unfortunately, and I think that requires very serious assessment to understand what's the diagnosis underpinning it.
Thank you. A couple of questions. So can mood stabilize, I know we did touch on it and you said mood stabilizers are not used in PMDD. Are there any instances where they do work for PMDD or they would be prescribed?
There are research trials of this. I'm thinking about one on quetiapine. So there are trials to see whether mood stabilizer work for PMDD. Currently, the evidence for treatment in PMDD, there is, for example, I'm always surprised that there is no nice guideline for PMDD. There are no many guidelines, and actually IAPMD has done a beautiful book for a guide for people with lived experience, but I find it very, very useful for healthcare professionals as well. So in short, the evidence I don't think is robust enough to indicate them. And also some of the mood stabilizer can give symptoms, can give side effects such as weight gain or sedation that might not be that pleasant if you already have PMDD. So I would say, at the moment, no, it's something that a very healthcare professional should decide about, really. Is something I would not take lightly. That is my answer.
Thank you. And so someone's just asked about the book. So we have produced, it's just in the final stages, an ebook, which is a very comprehensive guide to evidence-based treatments for PMDD. So it's very much in the final stages, just being edited and formatted. And we're hoping it will be available in April. However, it might be May. So do keep your eyes out for it. If you haven't subscribed to our newsletter, that's the best way to hear about it. Make sure you're on the mailing list. That's the best way to make sure you don't miss it. And also, I really hope is it Shani? I'm really sorry if I'm not saying that right, has asked if there's a resource to find doctors who are knowledgeable about PMDD in the USA. So we did have a provider directory online that has just been taken down for review, just while we kind of review the process of adding and keeping people on there. So for the time being, we would ask that people contact support@iapmd.org email. I know Sandy posted it earlier in the chat. That's the best way, and our peer support providers can talk you through finding someone. Ooh. Excuse me. There we go. Let me just have a look. How does lithium affect hormones?
We don't know. I wish we did. Lithium concentrations can be affected by hormones, so that because lithium metabolism is affected by hormones, apparently, which is something that, intuition, my intuition would have been not, because it's, most of the metabolism is through the kidney, but actually it seems that hormones actually play a role, probably about volume distributions, like you can feel a bit a bit of water retentions before your periods. Probably that is what is influencing lithium concentrations. But we don't know how lithium itself affects hormones, and we don't even know how valproate affects these symptoms that I was talking about, like polycystic ovary syndrome. There is a relationship between valproate and polycystic ovary syndrome, but it's absolutely not clear how these things work. And if you really, and I invite you, those of you that are more geeky, to just search the literature for these things, you'll find almost nothing. And also, you know, like especially when you're talking about cause effect, it's really difficult to disentangle the two. And there is very little literature on this one. I'm afraid I don't have a better answer.
No, I think that is sometimes the answer when it comes to these things. We don't know. There's so much that we don't know, and not just around premenstrual disorders, about the human body and the brain. You know, it's there is lots.
Women especially, because very often, and I want to stress this here, women are excluded from trials because they have periods, because they have fluctuating hormones. So most things are not actually studied in women. The women are, you know, or the women are treated like men. So I think there is a lot to be said in general on the female brain, if you want, that we really don't know anything, basically. It's really sad.
Most definitely. This is an interesting one. So I'm trying to get through as many as possible. I know I'm aware of time. I'm not sure how long you have, Professor Di Florio.
I do have time.
You do have time? Okay. So we'll keep going through them. Again, if you keep your questions sort of quite general, we can't answer ones that are specific to your individual care. So please sort of make them rhetoric, etc. So Julie has asked, have you seen women whose symptoms don't subside once menses occur? So I'm guessing talking specifically about PMDD there. Do correct me in the comments if not Julia. But in terms of the classic sort of PMDD picture, you know, only symptoms appearing in those windows, do you see people that it extends after the period has ended?
That is interesting, because if we use again the DSM approach, that is not PMDD. So I can't see a person, the moment in which the person does keep having symptoms, that's not PMDD according to DSM. It's still a person that's suffering, and the suffering still needs to be addressed. If the symptoms are less severe after the menstruation, it can be premenstrual exacerbation. So you can have exacerbation before your periods of another disorder. Another thing that, of course, is not studied and not discussed is stuff like endometriosis in people with PMDD. So you might have two different things that are happening. So you might feel horrible after you had your periods because of other, you know, like during your periods, because of endometriosis, of other conditions associated, you know, gynecological disorders or stuff that have not been recognized. So there is also that element that needs to be considered. But if we want to be rigorous with DSM, again, with these manuals and that definition, if symptoms persist in the follicular phase, that's not PMDD.
Yeah, and I agree. And if it's a consolation, we do see people within support groups who do have that experience that perhaps PMDD does kind of roll over, but they do have that clear window. So Jen has just asked us to touch again on the difference between PMDD and PME. So we'll do a quick recap. So PMDD is the symptoms are only visible, only occurring within the luteal phase, within the premenstrual phase. So that's within a week or two before your period. Whereas PME is when you have an existing condition, so such as bipolar disorder, depressive disorders, eating disorders, alcoholism. It's present across a lot of conditions where you have that condition at a chronic basis all the time. However, your symptoms worsen significantly during the build up to that period, and then again drop down to a lower, well, not necessarily constant, but to a lower level after your period. So it's like a premenstrual worsening of symptoms. Is that correctly described?
Yes, absolutely. I would say, which is something that I hope I'm conveying here, that these are just labels we use and don't make the suffering of a person more or less legitimate. if you feel unwell, you feel unwell. These labels are just to communicate between doctors and to find a treatment that works for you. Diagnoses need to be useful. In the moment a diagnosis is not useful, whether it's valid, like whether it's scientific, it doesn't matter. It doesn't work for you, and that is what matters. It's, like diagnoses need to be useful. And I think there is it's important to label stuff sometimes, to give a name to stuff. And very often I see patients are relieved by having a name to the suffering. At the same time, a name sometimes, I think name can be constrictive. So, again, people have so much stuff going on in their life, and sometimes name are really.
It's categorization, isn't it? And I think it can be really frustrating. I think getting that diagnosis as a patient can be, I know for me, sort of finding out about PMDD was just so validating, and it meant that I could kind of find my people who understood what I was going through. But I think also it can be frustrating for people, but that there has to kind of be that categorization, doesn't there, for research, for cycle science. There has to be kind of boundaries so that research can occur and happen. I'm just going to try and find some more questions. So a couple of people asked if you can get CPD credits for this webinar. Unfortunately, we can't as an international organisation. It's incredibly difficult for us to afford and manage. We can do a certificate of attendance if you want to email me at laura@iapmd.org. I am really happy to do that. Let me have... A couple of people have asked, so if they have, and I'm not sure if this is, I don't think they're UK based, but how would they go getting if they've been given a diagnosis of bipolar disorder and in time it's shown that they have PMDD, how to get that diagnosis reversed? Is there a sort of process for doing that? Is it as simple as going to talk to your doctor, or is there a kind of process that needs to happen?
I think they're both two very difficult conditions to diagnose. So first you want to make sure that your doctor knows what, knows the bipolar from the PMDD. And second, I would not, PMDD in the context of, because bipolar disorder, if you have had bipolar disorder in the past, so episodes of mania, clear bipolar disorder, and then you develop PMDD, the first treatment, I would be very careful of prescribing you as a first option an antidepressant, because although now you no longer have the high mood in the moment in which you go to your doctor, you're still vulnerable for that high mood. So your doctor needs to know that, because otherwise you might get an antidepressant that may trigger a new manic episode. So I think there is also that thing. And I think it's okay to have a history of bipolar disorder and suffering from PMDD. We see that a lot. And, there is nothing in DSM that says in two different moments of your life, you can't have them both. It's just that unfortunately, the bipolar, vulnerability, that this bipolar thing is always there with you. It's a risk. It's not real. It's not that you have that at the moment, but it can always come back. So that needs to be disclosed with the doctor.
Thank you. And so I've been asked a couple of times, you touched on how sometimes cannabis can have a negative effect on mood. So a couple of people asked, is that specifically cannabis that includes THC, or would that include CBD as well? Do we know an answer to that?
So what we know is that pot, the one that you buy, in countries where it's legal, you buy, in countries it's not legal, you don't buy from, reputable sources, that is usually not good. And there is actually evidence that is associated with, it can trigger in people that are vulnerable to psychosis. There are people that report, however, benefit from that. It's something that usually the person knows whether they get a bad experience out of it or a good one. But I also would say, that is, the concentration of the active substance in cannabis is increasing in the one you buy. So there are also secular trends in that cannot be disregarded. For the oils of the preparation with CBD that you find around, for those, I don't think there are randomized controlled trials for this. It's also worth bearing in mind that the response to placebo, especially in PMDD, is really high. So you would want to have placebo-controlled trials, and for these substances, also long-term treatments. I know that culturally, we are going towards that direction. This is a direction that is much, I think, more convenient from many points of view than 2 years of very hard psychotherapy, weekly, taking out everything you have in. And that can also be very scary, but I don't think there is enough indication, especially on safety. I hope that answers the question.
No, really helpful. So I'm just going to do a couple of people asking about resources for doctors. We do have on the website, if you let me just share it here. We do have treatment guidelines available for providers that mainly cover PMDD. There's not an awful lot of research on evidence-based treatments for PME, and of course it depends on the condition, if it's generalized anxiety or bipolar disorder, eating disorder, all the treatments are going to be different from person to person. So let me just add those here. If you wanted something to take to providers, that's really helpful there. I would say we're just going to do, I think, one more question. Sorry for those we didn't get to answer. I would say if you head to our FAQ on the website, and we have a really packed full knowledge base of answers, and a lot of the things you're asking here are answered on there, so you can just use a keyword etc. in there to try and find what you need. So let me have a look. Someone has asked, and I think this is an interesting one. So does PMDD symptoms end once menopause occurs, or does menopause also create difficulties due to the change in hormones? I think if I kind of touch on that one. So we have a page on our website for that as well. So it's just iapmd.org menopause, and it's also covered in the FAQ. Essentially, perimenopause can be very difficult for those with PMDD in the build up to total menopause. Can be really difficult because obviously those hormone levels are fluctuating quite wildly, and it can be difficult. However, when you are in full menopause, there's very little fluctuations in the hormones that are at a low level. So generally a lot of people find full relief, if not a very good relief from symptoms. There we go. Okie dokie. So I think we are going to, go on.
I see a question about genetics, which is what I'm doing.
Perfect. Well, let's do that one then.
Absolutely. Sorry about this. Heather is asking about genetic mutations. So our main study is on genetics. And what we know is actually that, as everything, is not that simple. So it's not a single genetic variation that probably influences your vulnerability to PMDD, but it's a lot of variations in the DNA. So it's true that, as you say, there are those specific genes that have been involved, but actually, if you look at the whole DNA, which is millions of markers, it's actually likely to be hundreds of thousands, of variants that have a very tiny contribution to the whole risk. And if you have all those variants in the, if you want, wrong way, you're more likely to develop PMDD. There are people that are more resilient because they have just few of them, but not all of them. So it's really many, many, many variations of the DNA of very small effect rather than one or two genes involved. And of course, this then interacts with the environment, with trauma. So that is my answer. And this is actually what the study we're running is about, to try to understand this.
So I was going to say, if people wanted to get involved, we will be doing some lives next week, but just for those people that are here that are interested, could you just give a brief, is it open internationally? I'm trying to remember.
The survey is open internationally, but unfortunately the DNA study, it's at the moment open only for people living in the UK, and it doesn't matter whether you have PMDD now or you have had it historically, or if you've never had that diagnosis but you feel now you have the symptoms. We have some mood diaries that you can do for 2 months, and then, you know, like we would use them for research, but we give a copy to you that you can send to your doctors. I must say, I know our diaries are not looking fab, very user-friendly. We are working on that at the moment. We are geeks, really, working to make them more user-friendly. So we do this for people in the UK. We might or might not send you a spit kit, so you can actually just provide a saliva samples for your DNA. And of course, everything is anonymized. We ask for people for home address just because we want to send the samples. We need to know where to send samples, and also we will keep you informed with the results in a few years of the general study. You know, like we will keep you updated with our research more generally to know how your data have been used. So this is basically the study. We try to understand what genetic variations can make you more likely to develop, you know, like premenstrual dysphoric disorder or other disorders.
Wonderful. Well, thank you so much for your time, and thank you everyone for coming. There's been a really good turnout and some really good questions. Sorry we didn't get to all of them. If you have any other sort of general questions, I can't answer medical ones, but if you can't find what you're looking for in the FAQ, feel free to email me, laura@iapmd.org. If you need support or you're looking for information or doctors that can help, please email support@iapmd.org.